Going live now.
Yeah.
Science plays a vital role for economic development and societal well-being. Understanding this, the Academy of Sciences Malaysia was established with a mission to be Malaysia's thought leader in all areas of science, technology, and innovation. To realize its mission, ASM harnesses the nation's top scientific minds to chart the STI direction and facilitates the implementation of an innovation-led economy for the country. ASM's commitment lies firmly in fostering a culture of excellence in STI in Malaysia. ASM does this by providing independent, credible, relevant, and timely STI input of national and international importance to the country. Our network of expertise comprises Malaysian scientists, engineers, and technologists who specialize in various disciplines. The Academy assists in upgrading the nation's technological capabilities in the industrial sectors by producing high-quality publications such as peer-reviewed journals, monographs, and books. In addition, ASM also provides input on current and future technology trends to be considered and taken up by the government in driving the nation's economy forward. To provide Malaysian scientists with the best opportunities and exposure, ASM actively extends its international networks and collaborations. It currently has a range of multilateral engagements with renowned scientific institutions worldwide. The Academy also champions the need to grow the right talent in STI by cultivating interest in science, technology, engineering, and mathematics to the younger generation. In short, the Academy's ethos is proudly defined as Think Science, Celebrate Technology, Inspire Innovation.
Thank you very much. And welcome to all attendees, and thank you for spending your afternoon with us for this webinar in conjunction with World Health Day. This webinar is organized by the International Science Council Regional Office for Asia and the Pacific, together with the Mahathir Science Award Foundation and the Academy of Sciences Malaysia. This webinar is also part of a TropSci webinar series, The Future Belongs to the Tropics. So for those of you who are just joining us for our first webinar, you can view our previous webinars through our YouTube page, Facebook, and also on social media, other social media as well. Just to inform everyone that this webinar is also part of the National Science Week here in Malaysia, which is organized by the Ministry of Science, Technology and Innovation. So this year's theme is Science for Health. So this webinar is very connected with the theme of this year. And so we are very excited to have with us a panel of very good experts with us here today. So without further ado, I would like to invite academician Dr. Mazlan Othman, who is the director of ISC Regional Office for Asia and the Pacific, and is also the chair of the TropSci 2021 conference. So the floor is yours.
Thank you, Sufyan. I think I'm fine, right? Can you hear me?
Yes, we can.
Good. Thank you. A good day, ladies and gentlemen, and a very warm welcome to this series of webinar on the theme, The Future Belongs to the Tropics. Some of you who are following us, and thank you so much for following us faithfully, you will hear about what is our motivation for dealing with that the future belongs to the tropics. But for the benefits of those joining us for the first time, let me explain again. Thank you. Now, the tropics is resource rich. As a region, it accounts for 40% of the world's total surface area, but hosts nearly 95% of the world's mangrove forests and approximately 80% of the world's biodiversity. 54% of the world's renewable water resources are in the tropics. 82% of the world's living languages are spoken in the tropics. I'm most impressed by that fact. So by 2050, the region will host more than half of the world's population and 2/3 of its children. But at the same time, unfortunately, 85% of the poorest people in the world live in the tropics. So while tropical nations have made significant progress, they face a variety of challenges that demand focused attention across a range of development indicators and data in order to achieve the SDGs. So to propel the attention of scientists and policymakers to the tropics, the Academy of Sciences Malaysia established the Mahathir Science Award that gives $100,000 to scientists who make significant contributions to tropical sciences. To support this prize, we are organizing the International Conference on Tropical Sciences. You saw that loop in the beginning. To see what the contributions of tropical sciences to sustainability, or abbreviated to TropSci, from 25th to 27th of October 2021. We hold activities to build awareness of the goals of TropSci, to attract participation among policymakers, implementers, both in the private and public sectors, as well as researchers. So far, we have had 8 webinars covering mangroves, youth, engineering, coffee, black gold of the tropics, tropical cities, tropical mountains, and tropical forests. So today, we present to you a webinar in conjunction with World Health Day. Over the past 50 years, World Health Day has highlighted important health issues like mental health, maternal and child care, and climate change. The theme for this year is building a fairer, healthier world. Now, we are painfully aware that the COVID-19 pandemic has highlighted and exacerbated the inequalities in healthcare throughout the world. Unfortunately, these inequalities are due to circumstances which are attributable to where one is born, where one grows, lives, works, and where we age. Most of these inequalities are not only unfair, but also preventable. The pandemic aside, the tropics, okay, now we're focusing on the tropics today. The tropics experience a higher burden of infectious diseases for several interrelated reasons. The region's climate and ecological characteristics actually increase the likelihood of disease transmission. In the tropics, there are greater rates of poverty and inequality, which are associated with poor nutrition, low rates of education, poor access to medical care, and poor sanitation. All these factors contribute to the disproportionate effect of infectious diseases on its communities. Well, we have an inspiring lineup of experts to highlight these inequalities and propose actions to bridge them. We are particularly pleased to have Dr. Peter Singer of the World Health Organization as a keynote speaker. So, ladies and gentlemen, I hope you will get much insight and inspiration from our discussions today. Enjoy. Thank you.
Thank you very much for the welcoming remarks. And I think has been clearly, raised the point on health inequalities and also why we are focusing on the tropics. So a bit more of just informing that this webinar is also shared through our YouTube page. So feel free to share the video after this webinar to those who are not able to attend, and also to all the attendees that we have here. If you have any comments or questions that you would like to ask, the keynote speaker and also the expert panelists, feel free to ask the questions in the Q&A section, and then we will ask the questions to them during the discussions. So moving on, as mentioned before, we are very pleased to have Dr. Peter Singer here with us today, who is the Special Advisor to the Director General, Dr. Tedros, and Assistant Director General of the World Health Organization. So with the World Health Day, I mean, who better to talk about health inequities than the World Health Organization? So Dr. Peter Singer has a lot of experience at the international stage and is a great advocate for equitable health. So we are very grateful for his time, and it's such an honor for me to invite him to give his speech.
Thank you so much. It's a real privilege for me to be here. I'd like to thank the Academy of Sciences of Malaysia, the Mahathir Science Award Foundation, and thank you, Professor Othman, for those introductory remarks, and also a special thank you to my friend, Dr. Khor Swee Keng. It really is a privilege for me to be here on World Health Day, to be here with the other panelists who I'm really looking forward to hearing from. And let me just start by wishing everybody a very, very happy World Health Day. As Professor Othman mentioned, the theme of World Health Day this year is building a fairer and healthier world. And WHO is celebrating, the World Health Organization, WHO is celebrating its 73rd birthday today. That's the significance also of World Health Day, because the Constitution was signed on this day 73 years ago, or came into effect actually. And so it's really, really great to be with you on this day. My key message that I'd really like to emphasize, especially for the young people, the young scientists, the women scientists who are listening, is that equity is in your hands. Equity is in your hands. Equity is in our hands. So it's not something that is only an abstract concept that we're talking about. It's something very practical, and very practical that you can do something about, and very practical that you can do something about with science and innovation. And I think would really like to just put that message up front. Now, I'd like to use the lens of COVID-19, really the worst crisis to hit the world, certainly in the area of global public health in 100 years, and maybe in any area in basically the same time period that WHO's been in existence. A crisis of lives and livelihoods, 2.86 million people lost, tens of trillions of dollars of spending, many livelihoods destroyed. It's a terrible, terrible tragedy. And one of the key lessons of this tragedy is the theme of equity. Before delving into that, I'd like to just recognize that the very great importance of public health. And it was obviously one of the key issues starting right at the beginning in 2020. It's still one of the key issues. And I just want to emphasize for people not to let their guard down, keep public health measures intact, the physical distancing, the masking, avoiding poorly ventilated indoor spaces, and so on. The pandemic also shows the unprecedented progress of science. You know, when I was in medical school in the early 80s, we learned that it would take 10, 15 years to develop a vaccine. If someone would have told me at the beginning of this pandemic that within a year, we'd have the first licensed vaccine that received emergency use authorization from the World Health Organization, that we'd have more than 200 candidates in the pipeline, more than 50 in human trials, and a handful, several in use, I wouldn't have believed it. It's an incredible and unprecedented scientific accomplishment. But alongside, if you will, the fundamental importance of public health measures and the unprecedented progress in science, one of the most significant lessons of COVID does resonate with the theme for World Health Day, because COVID has shone a very, very bright light on the issue of equity and on the issue of inequities. These are inequities that happen among countries, and I'll use the situation of vaccine equity in a moment to illustrate that, or shall I say vaccine inequity. But first, let me just give you an example from where I come from, which is Toronto in Canada. And the reason I want to use that example is to illustrate that every country within a country has issues of equity and inequity. So in Toronto, it is the most racialized, lowest income neighborhoods that have the highest rates of hospitalized COVID. So for example, 52% of people in Toronto are from racialized communities, and 81% of hospitalized cases of COVID were towards the beginning of the pandemic. With intensification of measures, that number, that discrepancy has gone down, but it just shows how disaggregated data can also be used to address inequities. Those same neighborhoods that have the highest rates of COVID also have the lowest rates of vaccination. Highest rate of COVID, lowest rate of vaccination. And we're also seeing now, especially with the spread of variants, young people and especially essential workers who are ending up in intensive care units very, very sick with COVID. So the main point I want to make here is that even though we've seen the fundamental importance of public health, the unprecedented progress in science, COVID has shone an extremely bright light on the inequities in the world among countries and within countries, and especially the pre-existing socioeconomic inequities. This will be very important in the recovery, because hopefully, you know, if 2020 was the year of public health measures and 2021 is the year of vaccines and vaccine equity alongside public health measures, hopefully 2022 will be the year of an equitable recovery, which has to be led by primary health care. And so there's a dark side to this. There's also the opportunity to redress the inequities that have been exposed by COVID. So that's my second point, the harsh light that COVID has shown on equity and what we can learn from that and how we can use that information to recover. I'd now like to delve into the question of vaccine equity, or shall I say vaccine inequity. So at this moment, there's about 315 million people who've had at least one dose of vaccine. About 600 million doses of vaccine have been administered worldwide. But this has been done in a very inequitable way, just empirically. In high income countries, about 27.7% of people have had at least one vaccine dose, but that compares with 5.2% of people in non-high income countries. That's a five-fold difference. And that's the snapshot of vaccine equity, or shall we say vaccine inequity right there, equity among countries. Now, you have to ask yourself when you're thinking about vaccine equity, what is it that's scarce? What is it that's the choke point? And I'd like to propose that we think about that in terms of the 3Ds. It could be dollars, it could be doses of vaccine, or it could be domestic manufacturing. There's no question that there is a scarcity of dollars. So for example, the COVAX facility, which is a facility developed by the World Health Organization, Gavi, the Vaccine Alliance, the Coalition for Epidemic Preparedness Innovation, and UNICEF, the COVAX facility, which is really a lifeline for many countries in the world and an insurance policy for others in terms of distribution of vaccines, has at the moment a $22 billion funding gap. This is a small amount, though, compared to the tens of trillions of dollars in stimulus spending and economic damage that's happened in the world. So there is a need for more money. It may not be the primary choke point at the moment, but dollars is a key piece of scarcity and a key piece of vaccine inequity. The second possibility is doses. And indeed, sharing of vaccine doses is extremely important. So to stick with the example of the COVAX facility, in the last month or 6 weeks, this facility, which has a 2 billion dose target by the end of 2021, has delivered 36 million doses to more than 86 countries. And most of those countries would not otherwise have had, or many of them would not otherwise have had vaccination. So sharing doses, including through COVAX, is a very, very important piece of the puzzle. So dollars, doses, but the main point I want to make, and this is the beginning of 2021, my friend and colleague, Dr. Tedros, issued his 100-day challenge. He said, in the first 100 days of 2021, he'd like to see vaccination start, especially for health workers and older people in every country in the world. And in fact, as of yesterday, about 190 countries and economies had started. But as we look forward, the issue is completing the job. The issue is the essential health workers. The issue is and in regions themselves. And so in this section on vaccine equity, I want to say we're quite far from vaccine equity. We can think about it in terms of dollars, doses, and domestic manufacturing. And all are needed. And we will need, as we go forward, to watch this space on domestic manufacturing because it's a very, very important piece of the puzzle. Now, I've talked about the significance of World Health Day and the focus on equity. I've talked about how COVID has actually shone a very bright light on equity and inequity within and between countries, including socioeconomic inequities that we can redress using disaggregated data and targeted policies in a hopefully what will be a primary healthcare-led equitable recovery coming soon. I've also talked about vaccine equity and how we should ask ourselves whether it's dollars, doses, or domestic manufacturing that's scarce. And dollars and doses are really very important, but so is domestic manufacturing, especially as we think about the variants and the ongoing threat of pandemics. In closing, I'd like to come back to where I started and the message that equity is in your hands. And this is especially a message I'd like to extend to young people, to young scientists, to women scientists who are so important in the scientific enterprise. You know, one of the key pieces of advice that I like to give to young people is to find a problem and solve it. find a problem and solve it. And nowhere is that advice, I think, more important than it is in science, broadly defined, whether it's data science and disaggregated data, whether it's the vaccine science, whether it's diagnostic tests, whether it's oxygen, whether it's health services and health systems, whether it's the social policies and social protection that are so important. Find a problem and solve it, because only if all of you watching this and all of us are solving problems, that's actually how we will have the path to recovery. And it's also, I think, important for a diverse range of us to be solving problems. And so another bit of my advice is to lean out, career advice, and make way for a diverse range of voices and elevate those voices. To find a mentor, maybe one of the things I didn't do well enough is to find enough mentors. To embrace failure, because it's inevitable as you're finding problems and solving it, and to go where other people are not. In other words, if you can find a problem that not many people are working on, but you think is important, that's the problem to be solving. And the closer you can connect those problems to equity, the better. So in closing, maybe one of the main lessons of the pandemic is that character matters, kindness matters. And so in closing, again, I just want to thank you for the privilege of addressing you. I know that together with your academy, with your foundation, and with the group of people listening here, we will be able to recover from COVID. There is light coming. There are difficult days ahead, but hope is in front of us. And please remember how much character matters and how much kindness matters in the pandemic, alongside science, alongside public health. Thank you so much. Equity is in your hands, and I look forward very much to the discussion period, to the other panelists' presentations, to the discussion period. And in fact, I'd be very glad to stay in touch in an ongoing way on Twitter. I'm at Peter A. Singer. Let's keep the conversation going. Thank you very, very much, and back to you. It's a privilege to be with you. I look forward to staying with you for the duration.
Thank you very much, Dr. Peter Singer, for that very inspiring speech. And I think personally, I have to say that I agree that he is very active on Twitter. I have recently followed him, and I have to say I've learned a lot during the last few months. And so I think I agree with what it's very good to follow and find those mentors and to learn. So thank you very much for raising a lot of very good points on socioeconomic equities, vaccine inequities, and how 2022 is, the aim is for it to be an equitable recovery year. So we do have some questions that have been directed to Dr. Peter Singer, but I think we can keep it for the panel discussion session later. Dr. Peter Singer will also join in the discussion session. And so I will pass on the floor now to Dr. Swee Keng, who has agreed, who is our moderator for the panel session.
So, Sufyan, thank you very much. And it's a pleasure to be here with everyone. I want to wish everyone a happy World Health Day once again. My name is Swee Keng, and you can feel free to call me SK. I'll be pleased to be a moderator today. In fact, there is only one job for the moderator, and that is really to make the panelists look good and to highlight the work that they have done. So to that end, allow me to very quickly move on to introducing Ms. Anne Penny, who will be the first panelist, and Anne will be presenting some slides about the report that she and her colleagues have done called the State of the Tropics Report. But as Anne gets ready to share her screen, what I'll do is to introduce her briefly. She's currently based at the State of the Tropics project, which is based in the James Cook University in Australia for the last 7 years. In some career highlights, two highlights that I'd like to pick up. In the National Climate Change Adaptation Research Facility, and coordinated 8 networks and brought them together. That means thousands of researchers and practitioners to develop innovative solutions for climate change. And she's also particularly proud of her small role, she says, in the successful campaign for the International Day of the Tropics, recognized by the United Nations and first celebrated in 2016. And thank you so much for your service all these years. The floor is yours for you to take us through the State of the Tropics report. Over to you, Anne.
Thank you very much, Dr. Korswi. It is such a privilege to be here amongst this group of speakers. I'm really, really chuffed. So thank you so much for allowing me to talk about my little project with you all today. I'll just start off by talking about the State of the Tropics in general. It's a project led by James Cook University, which is an Australian university in tropical Australia, in northern Queensland, but includes institutions from around the world who are either in the tropics or have a particular interest in the tropics, and they sit on an advisory panel for that project. The role of the project is to analyse a range of environmental, social and economic indicators that help us answer the question, is life getting better in the tropics? So we produce a big State of the Tropics report every 5 to 6 years, which is kind of like a human development report for the tropics, if you like. But we also, in between, produce smaller focus reports, such as, the 2019 report that we published on health in the tropics. So as we've already heard, human health and wellbeing are absolutely central. Prosperity, sustainability and stability of human communities, particularly in the tropics. But I think the last year and a bit has shown us that it's important all over the world. This report covered sort of recent and historical status of health and wellbeing across the whole of the tropical regions. We used existing data. We didn't collect any of our own data from places like the United Nations, the World Bank, World Health Organizations, but also NGOs and national statistical bureaus as well. This particular report covered infectious disease, non-communicable disease, maternal and child health, mental illness, substance abuse, and accident and injury. We also had a brief look at some of the resources for health, including human capital and infrastructure. So, sorry about that. I think Maslin touched on this before, but we really need to start by talking about who are the people of the tropics. We're talking about 3.3 billion people, so 43% of the world's population is tropical, including most of the world's children. So currently now, more than 50% of the world's children under 15 years live in a tropical place. You can see by that very large-scale population graph that the demographics of the tropics is quite different to the rest of the world. And I think we probably, when we talk about health in the tropics, we also need to start by talking about how far we've come. If you have a look at this image here, it shows life expectancy at birth across the world in 1950. You can see that the vast majority of tropical countries actually had a life expectancy of less than 50 years of age, and that is about 70 years ago. Now, if we have a look at 2018, you can see a vast improvement. So globally, life expectancy grew by 24 years between 1950 and 2018. And now most tropical countries do have a life expectancy of greater than 60 years. There are some exceptions that are often associated with conflict, particularly in Central Africa, but we need to, I guess, acknowledge that absolutely extraordinary progress, greater than any other period in human history. And I'm sure the other panelists are going to talk a lot more about social determinants of health and underlying factors, but I thought I probably might just show this graph, which is an indication of extreme poverty. The solid line is the proportion of people living in extreme poverty, and the dotted line is the number. 85% of the world's poorest people live in tropical countries. However, that has definitely declined since the early 90s and since the turn of the century. Unfortunately, due to a number of reasons, which we don't have time to talk about, that progress has actually slowed even prior to the COVID pandemic, and has actually resulted in a small increase in the total number of people living in extreme poverty in the tropics. prior to 2020. So something to keep in mind for future statistics. We've heard a bit about the burden of disease being higher in the tropics. I just wanted to show you how much higher. These are the three major, I guess, infectious disease killers, if you like, that cause the most deaths of infectious diseases. HIV, malaria, and tuberculosis. And you can see there how clearly that gap exists, despite improvements, particularly in HIV, particularly in tuberculosis. Those incidences, the prevalence of HIV and the incidence of tuberculosis and malaria have declined. I have to applaud countries like Sri Lanka, Timor-Leste, Guyana, diverse countries that have managed to eradicate malaria in recent years. So there's still been a huge amount of improvement there. Neglected tropical diseases are a group of about 20 infectious diseases and other maladies, because it includes snakebite, that actually affect more than 1 billion people worldwide. They're called neglected because although they're widespread and they're debilitating, they quite often don't kill the people that they infect, and they tend to be diseases of poverty. Dr. Peter Hotez from the Baylor School of Tropical Medicine is actually, he's an expert in NTDs, and he's actually said that he thinks COVID-19 may well become an NTD, and that may be as a result of that vaccine inequity that we just heard from Professor Singer. There has been great improvements in some neglected tropical diseases that have seen close to eradication, like guinea worm disease, African sleeping sickness, but things like dengue, schistosomiasis, melioidosis have not shown any improvement at all. So more work to do amongst that 20 or so infectious diseases. Now, today's theme is about a fairer and healthier world, and the only way we can make a fairer and healthier world is to make sure that the most vulnerable members of our community have access to the healthcare that they need. And generally, across the tropics and the world, the most vulnerable are women and children. So these three metrics here are maternal mortality, newborn mortality, and under 5 mortality. You can see that there has been considerable progress in this space since the turn of the century, where we've seen deaths in maternal and newborn decline by nearly a third, and under 5 deaths by nearly a half. This also contributes to rising life expectancies. But I think also for the tropics, we need to consider that 80% of all maternal deaths globally occur in the tropics. So there is a huge inequity. Also that this progress had slowed prior to the pandemic. And this one is a real, obviously personally, and I think worldwide, we need to be concerned about women seeking healthcare during the pandemic and what impact that may have had. And we will find out, I'm sure, within a few short months. There are other impacts as well. Non-communicable diseases are things like heart disease, stroke, cancer, chronic respiratory disease, and diabetes. Those diseases are increasing in prevalence in the tropics and adding to that burden. So you are still, there's still a higher mortality rate of NCDs in the tropics than in the rest of the world, despite prevalence kind of often being considered lower. There are also other forms of injury. I won't go into details here, except that to say that injury and death as a result of road traffic accidents particularly have increased in the tropics and is disproportional. More than 50% of all road accident deaths occur in the tropics, where only 27% of registered vehicles occur. Some of that may well be because of this next slide. Now, this is a really coarse way of looking at health systems, so I apologise for this. There's far more complexity needed, but I just wanted to show it quite starkly here. These graphs refer to doctors, nurses and midwives, and hospitals per capita in the tropics, and you can see how big that gap is. I'm sorry, my slides have stopped working. I might just finish up there if I can find my right slide, but I'm going in the wrong direction, it seems. I just wanted to finish up by saying, you know, in the tropics, we live really close to the environment all the time. So these kind of diseases that we're dealing with, COVID-19 or any other infectious diseases, really need a full systems approach to dealing with them. And hopefully I might get a chance to talk a little bit more about that later. So thank you very much.
And thank you very much for your lovely presentation, where you've sketched up for us some statistics that show that we seem to be trending well, but progress has seemed slowed, especially before COVID. May I ask you a question, Anne, and it's a complex one? Given the wide variety of problems, how should countries prioritize which problems to fix first? In other words, what is the framework for countries to prioritize which problems that they should fix first? Over to you, Anne.
Well, that is definitely a really big question in terms of prioritizing. I think we do see that already, that countries do that very well. When you look at something like the Global Fund to fight HIV, AIDS and tuberculosis, because those diseases, particularly in poorer tropical countries, have the greatest economic and social impact, they tend to get the biggest focus. And that is, you know, an appropriate way to deal with it, because not only are those diseases have a huge impact, they are also preventable. There are treatments available. So, you know, with the right amount of focus, those health issues can be dealt with. For me personally, and for all of the work that we do in the State of the Tropics, so that's, you know, across all aspects of development, what I would say is that tropical challenges require tropical solutions. So focusing on your capacity, your research capacity, health worker capacity, science worker capacity, engineering capacity within your own country, holding on to your experts as much as you can, really does, you know, there are a lot of unique challenges that the tropics holds in terms of its climate, its environment, colonial histories, all of those things that are best addressed by knowledge created within the tropics.
And thank you very much for sharing your thoughts with us about the state of health in the tropics. And as Anne was speaking, I'm struck by the fact that a lot of the conversations are actually outside of the formal health sector, so requiring us to talk about the social determinants of health. And who better than Professor Vivian Lin from Hong Kong University to talk us through this. So before I cede the floor over to Professor Vivian Lin, allow me to introduce her very briefly. She's currently the Executive Associate Dean in the Hong Kong University School of Medicine, also concurrently a Professor of Public Health Practice, but with 30 years of experience in teaching, in researching, and also the practice of public health and health policies and systems planning. So we're very pleased to have Professor Vivian Lin. The floor is yours for us to listen to you talk about the social determinants of health. Over to you, Professor Vivian Lin.
Thank you very much, Sui Kang, and happy World Health Day, everyone. It's great to be with you, and this is a terrific event to think about the post-COVID era and how do we build back better to a fairer and healthier tropics. I think the issues of equity and the particular challenges of the tropics have been, you know, really well outlined by the three speakers before me, and so I suppose there's a question of what more can I say? So I think what I'll do is I'll pick up on Peter's focus on vaccines and start from there to perhaps illustrate some of the particular challenges we need to overcome and what we might do. You know, for now, it will be 18 months, 2 years before the world starts to resemble something like the pre-COVID era. And we're banking a lot on this vaccine. And what we have seen in the last year is this incredibly successful collaboration globally across scientists, and we need to celebrate that. But we also need to recognize that vaccine in itself is good science, but it's not public health. Public health means we actually have to get the vaccines to the people at a level that is sufficient to protect everyone. And of course, there's been a lot of discussions about prioritization in vaccine access, in distribution, and that recognizes many of these inequitable issues across the world and within countries as well. You know, we see that there's an emphasis on people who are frontline workers, people who are perhaps in aged care residential facilities. And this reflects obviously a certain pattern that we have seen over the last year. But I think what we need to also understand is some of the underlying issues, the insecure employment that's often there for people on the front line, people who have to work multiple jobs, the people who work in crowded houses who cannot socially distance, the poor housing conditions as we have seen in Hong Kong, where the sewage system may in fact be one of the factors that transmit disease. So these are issues which have to be recognized if we're going to do this well. Now, of course, any kind of a vaccine delivery system needs to ensure that the logistics and supply systems are in place, that there is the workforce and the facilities to deliver the jabs, and also the kind of outreach to get the community out there. And when we think about the tropical countries, with the issues as already have been outlined, we see that many of these countries will fall short on the resources required, the health workers to inoculate, the financial resources to have the vaccines, the transportation systems that's required to get the vaccine to the people, and indeed the refrigerators that are necessary. So even with these systems in place, we still have problems of the social determinants of healthcare access. And of course, having spent 5.5 years as the Director of Health Systems at the WHO in the regional office in the Western Pacific, I'm thinking in particular of the countries in this part of the Asia Pacific region, where to access the vaccines, there are geographical areas, many remote places, no roads. There are financial barriers to access, as many of our countries are still in the process of building a health financing system that could cover for all. We have this huge diversity of language across the countries, the tropical countries in this region. And many minority groups do not necessarily speak or read the dominant language, and interpretation may or may not be available even from family members. The low health literacy in particular population groups means a more limited understanding of the benefit of prevention, because what people have always done is delayed seeking care for all these other access barrier reasons until it's very late. And for so many countries, without a proper community support system, social welfare system, we have single mothers who may have to care for multiple children, for aging and disabled relatives. So the care burden also limits the opportunities to access healthcare. And finally, in many places, there's a real barrier in terms of trust in the quality of healthcare, a belief that the services are poor, and indeed, in many communities, it is the newer graduates, people who really only want to be in those communities for a short time, and people who have lesser education. So in other words, the disadvantaged population experience disadvantage in accessing health services. It's not only an issue of financial protection, but it's multiple dimensions of disadvantage. And we have to understand intersectionality as a fundamental phenomena. But of course, it's not just healthcare access, it's the health status as well. And we see the socioeconomic gradient in tropical countries as we see elsewhere. But I think it's worth highlighting some particular issues. The environmental hazards that may promote infectious disease transmission is important. And if we have people, a lot of people in squatter settlements, we're seeing more vector-borne diseases, we're seeing problems because of poor water and sanitation. And the poor housing also means that when natural disasters strike, people's lives become destroyed. And in tropical countries, especially in the Western Pacific, we see more natural disasters than any other part of the world, be they earthquakes, floods, volcanoes, typhoons, what have you. And of course, the disadvantaged population who live in the less, the worst housing have less disposable income. So the issue of food supply, of nutrition, of delaying healthcare is there. They have less opportunity. They're not able to afford schools. So they end up in more unskilled jobs and unstable income. And when they do have jobs, it's often ones with greater exposure to occupational health and safety problems, all of which also means that you have to worry about making the ends meet and therefore the mental health issues. So this combination of other burdens of disease, the risk of natural disasters, the limited healthcare, all have, we've seen these become exacerbated through this COVID period. So the question becomes, how do we actually build back, recognizing these inequalities, as well as accentuate some of the positive things that have happened? And so I want to say that we need to really consciously think about building back better with equality by design. We can't just let the conversations happen and not consciously work at it. Because if today is the result of yesterday, why would we want to go back to yesterday? Why would we want to expose the same social, economic, and health inequities when the next pandemic comes? And there will be more, and not just pandemics, but the next natural disaster. We have to rebuild the trust, build the legitimacy of our institutions, and really develop the leadership across society. We've talked about how universal health coverage and primary healthcare is a foundation, but we also have to strengthen our public health infrastructure, link that to social protection systems. We want to harness the digital health developments. That is one of the positive things that we have seen, and we want to make sure we continue to develop green infrastructure as we move forward. We can also think about the regional connections we form across tropical countries to strengthen the supply chains, the production bubbles, not just travel bubbles, and the kind of learning across cities that can happen so that those countries with shared cultures, institutions, can create the kind of space for conversation. And finally, globally, we need to re-emphasize solidarity and equity across political and economic systems so that we can really look at how knowledge and science can serve humanity and not just be part of our geopolitical problem. Thank you very much.
Thank you, Professor Vivian. It's a very rich set of comments that you have provided. But one thing struck me you did not even mention the word hospital one time. And societies may even think that healthcare is hospital driven or clinic driven by doctors. My question to you is, how can we get governments and citizens to reimagine healthcare, that healthcare is more than just hospitals and it's everything that you mentioned? So how do we shift the thinking and understanding of human beings and citizens and voters and taxpayers and governments to see healthcare as beyond hospitals and to include employment, housing conditions, and the burden of care and the other social determinants that you've mentioned?
Well, I think, hospitals are often seen as the temple of health in many countries because it's how people have come to know Western medicine. It's where they think you get the good doctors and the specialists. And I don't think we want to do away with that. I think we still need good quality medicine when people are acutely ill and need that. What we really have to do is to build fantastic primary health care that can reach the community, that build the trust, that support people in prevention. And I think by doing that, people will learn about what good prevention is, what good community healthcare is. Now, there are many things you can do from a policy viewpoint to shift that. But I think fundamentally, it's not about taking away the hospitals. It's actually filling that incredibly important gap that is missing.
Thank you for that, Professor Vivian Lin. It's a pleasure to have you tell us about the social determinants of health. And as we listen to the conversation, and we understand that a lot of tropical countries will need tropical solutions to the tropical challenges that they face. So with that in mind, I'm very pleased to introduce Professor Aminata Saldialo, who's based in Dakar, Senegal. Professor Aminata will speak with us about the importance of education, community education, in order to achieve better health outcomes. As a brief introduction to Professor Aminata, she's a professor of physiology at the University Sheikh Anta Diop in Dakar, also a special advisor to the Minister of Higher Education of Research in Senegal. One specific thing I want to highlight from Professor Aminata's history is that she was instrumental in getting Senegal to be the first African country to introduce vaccines against hepatitis. And she did this on the back of research and then translated those research into meaningful and impactful policies. Professor Aminata, we're pleased to have you here with us for you to share your thoughts with us about education for better health outcomes. Over to you, Professor Aminata.
Can you hear me?
Yes, we can, Professor Aminata. We understand that you might not have video, so we're very happy to hear you.
Okay, thank you. I cannot get my presentation. You are sharing the screen, and just can we just leave? Excuse me?
Yes, Professor.
I cannot get my presentation because you are sharing the screen.
Noted. We will stop sharing the screen, and please go ahead, Professor.
Thank you very much. So I want to wish Happy World Health Day to all of you, and thank you, Dr. Shuken, to give me the floor. I think education for better health outcomes is a very, very important topic. What I can say is education and health have always been linked, but never as greatly as they are now. For more than 2 decades, researchers have noted a disturbing widening in the gradient. Year by year, scientists have warned that the health gap between those with and without education is growing ever larger. Based on reports, many reports, people with less education face a serious health disadvantaged. They have shorter lives, worse health, more risk factors, greater disability, high death rates, and generate higher medical care costs, are less productive at work, experience more psychological distress, have less healthy lifestyle. Globally, we can say that education has significant impact on health. What is the cause? Why does education matter more to health now? I think in today's knowledge economy, education paves a path to good jobs. Completing more years of education confers health benefits after leaving school, such as better health insurance, access to medical care, and the resources to live a healthier lifestyle and to reside in healthier home and neighborhoods. Education can also lead to more accurate health belief and knowledge, and thus to better lifestyle choice, but also to better skills and greater self-advocacy. Education improves skills such as literacy, develop effective habits, and may improve cognitive ability. So I think we have no doubt about the important connection between education and health. What then should we do to better tackle the burden of tropical disease? What then should we do to improve the health of our population? I think healthcare is necessary. We really need to improve access to quality health care for the disadvantaged, including adopting reforms that widen access to health insurance coverage, to improve the quality and reduce health disparities. But I think it's not really sufficient. Eliminating the adverse health consequence of a limited education will require other policies that target factors outside of healthcare, that cause people with less education to experience greater illness despite access to healthcare. Reforms are needed to improve access to a good education, better education from early childhood through college, but also to address related problems. I think diploma alone will not solve everything. Healthcare reform must be accompanied by change in social and economic policy that are win-win. We need to create economic opportunity for families while also saving lives and costs from medical illness. I think really that is important. Education is a key. What I can say is that education is a key, and we need really to reform our education system in tropical countries. Thank you very much. Thank you.
Professor Aminata, thank you very much for your thoughts about the importance of education. And everything you say is very true about how it can lead to better health outcomes, and education requires some socioeconomic reforms as well. Professor Aminata, allow me to ask you a question. There could be a bit of a chicken and egg situation, as in you need to have stronger education to get better health and to get, say, socioeconomic improvement, but you also need socioeconomic improvement in order to get education. In this chicken and egg scenario, Professor Aminata, would you please share with us some of your thoughts or your observations over the last few years of how we can actually resolve this chicken and egg situation? Over to you, Professor Aminata.
Yes, I think we do a lot of effort to really build a strong education system. I can speak about my country in Senegal. We do a lot. I think 40% of national budget is dedicated to education in my country. And I think it's really important. It's a priority in my country. And I think Senegal is a good example for other tropical countries in Africa. I think we put a lot of investment in infrastructure, but not only, also in training on skills. And I think this is very, very important. We train a lot health workers in rural area. And I think it's really the good way to improve things. And I think we need really to prioritize education in our countries.
What an excellent set of thoughts, Professor Aminata, and especially the fact that Senegal spends, like as you mentioned, 30% of your, say, national budget on education. That is indeed a very high number, and I think this is one of the solutions to resolve some parts of the chicken and egg situation. Thank you, Professor Aminata. And as our last panelist, and by no means the least, I'm very pleased to introduce Professor Dr. Awang Bugiba Awang Mahmud. Professor Awang is based in the University of Malaya, where he's a professor of epidemiology, and he also holds 3 separate appointments in 3 large entities in Malaysia: the Secretary General of the Academy of Sciences Malaysia, which is hosting this webinar today. He's also a council member of the Academy of Medicine Malaysia, and he's president of the Asia Pacific Consortium on Public Health in Kuala Lumpur, and he's currently directing the National Policy on Science, Technology and Innovation that takes Malaysia between 2021 to 2030 on behalf of the Ministry of Science, Technology and Innovation. Professor Awang, it's a pleasure to have you here, and we're very keen to listen to your thoughts about the community engagement for health and how communities can really be active participants rather than only passive recipients of healthcare in the tropics. Professor Awang, over to you.
Thank you very much, Dr. Koh Swee Keng. I hope you can view my slides here.
We can see you, hear you, and see your slides.
All right, thank you very much. Right. I'm going to talk very briefly for just about 10 minutes and borrowed some of these slides from my colleagues, Prof. Noran Hairi from the Peace Project and Associate Professor Hazrin Abdul Majid from the Partner Project, which I'm going to talk about in a minute. Now, speaking as an academic, epidemiological and public health research continue to generate findings with great potential to inform prevention and management, for example, of non-communicable diseases. But the actual translation of this broad array of knowledge into effective policies program has always been limited. And we know that we have lots of research findings, but uptake does not happen automatically because there are pull factors and as well as there are push factors. So depending on the motivation for us to research, and as academic research is part of the way of life for us, there are various reasons why we do research. It's promotion, passion, satisfaction, or because it's requirement for a degree or opportunities and so on. But whatever we do with the research is the one which really matters. So we want to make an academic impact, of course, in academics, but perhaps more importantly, we should go beyond the academic impact, which is the economic and the societal impact, where we make a contribution to the society and economy and its benefits to individuals, organizations, or even countries. I hope you can see this slide here. Sometimes the slides doesn't work as well. They don't work as well. Can you see the slides on twin dynamic?
Yes, we can.
Yeah, okay, right, good. Now, infectious diseases have not disappeared from the tropics. On the contrary, I think they are still there. And at the same time, non-communicable diseases, unfortunately, are increasing. We have high rates of overweight, obesity, diabetes, high blood pressure, and some people call this a twindemic. And some tropical countries are also starting to age, and quite rapidly too. So we have this twindemic and aging conundrum, which is happening now in the tropics. Let me take you back to an annual survey which is done by our Ministry of Health, Malaysia. Here I'm drawing on Malaysian results, where the National Health Mobility Survey, or what is commonly called the NHMS in 2019, found that there was an increase in diabetes among adults, for example, and it has been increasing for the last 10 years. The levels of hypertension or high blood pressure among adults has not decreased at all. So we can see that this continues to become a problem. And COVID-19 has shown that COVID-19 and NCDs plus aging makes for very poor outcomes. So you can see here these scenes from Malaysia, from the movement control orders, contact tracing, and so on, going among the community. So I'm going to take you through 2 case studies on community engagement we have done in the University of Malaya. The first is called the Partner Project. Partner stands for Participatory Action Research Through Negotiated Empowerment of Residents, which was launched in 2012. What we thought was we would like to do something in the community because we are situated next to a mixed development of expensive high-rise condominiums together with low-cost subsidized housing. And we know that urban issues affect a lot of health, so we needed to research and help the community uplift its health status through community engagement. So we were very gung-ho right from the very beginning. I was involved in the project from the very beginning. We had a lot of medical screenings, from which then we decided to do health education, try to reduce the rates of obesity and so on. We had health carnivals, we had free health screenings repeated just about every year until we ran out of money, of course. And then what we realized from this project was that community engagement helped us understand that there were many issues in the community, and being academics did not mean we could not do something about those issues. However, we also realized that short-term grants at that time, and this was just a 3-year grant, did not allow us enough time for real impact. And an opportunity came when our university introduced what is called the Grand Challenge Grant Scheme in 2014. This idea of a Grand Challenge project has been taken up by Ministry of Higher Education also, and MOSTI recently, but it was the University of Malaya which in 2014 introduced first the Grand Challenge Grant Scheme. And this led to this case study number 2, which is the Peace Project. So what is the Peace Project all about? The Peace Project stands for Prevent Elder Abuse and Neglect Initiative. And it was a Grand Challenge project which went for 5 years. Now, Grand Challenge projects are meant to produce outcomes beyond usual publications, conference presentations, and so on. And we were cognizant that there were 2 health policies for the elderly in Malaysia, which was introduced in 2008 and 2011 as a result of the rapid demographic transition in order to address issues which are related to senior citizens. So we had a 5-package program under the Peace Program where we wanted through a coordinated multi-step approach which involved multiple stakeholders across many communities. So it was bottom-up, multi-level, and it was interdisciplinary. So it involved academics and clinicians from public health, family medicine, geriatrics, from law. We had officials from state health departments from 2 states, the Negeri Sembilan and Penang State. We had the Department of Social Welfare, the federal, state levels. We had lots of community-based organizations. We had media outlets and journalists, and we even had a chef on board to try to help us. So what did we do with this project? So we talked about elder abuse, which is defined as a single repeated act or lack of appropriate action occurring within any relationship where there is an expectation of trust which causes harm or distress to an older person. So we were looking at a whole range of abuse, which was physical abuse, psychological, emotional abuse, financial abuse, sexual abuse, and even also neglect. So when we looked at this, we said that we wanted to examine these objectives, which was looking at the magnitude, the risk factors, the role of caregivers, the education and training to the healthcare providers, education training to the caregivers who were formal and informal, who provided care for the elderly. And we wanted to understand whether there were any gaps and whether there was a need to refine the law, for example, to address gaps through this comprehensive approach. And we, instead of having just a dissemination, which is the usual way that people do kinds of engagement, we thought we needed a real community engagement, which was a two-way process where we interact with stakeholders by discussing their issues, which shared expertise, which was two ways, their expertise as well as our expertise, and we solved common problems. So we had lots and lots of advocacy activities. We went through the media, several times through the media, and we even went on TV, on radio, and so on. And finally, also, we had lots and lots of engagement activities with the public. We helped the public understand. We wanted to know what was happening in the community as far as elder abuse and neglect was concerned. We took part in the Elder Abuse and Awareness Day. For example, for several years, we involved nurses, primary care doctors in the community, and we also trained the caregivers in the community who were responsible, formal and informal, who were responsible for taking care of the elderly, and to make sure that the people understood that taking care of the elderly went beyond what was normally thought of as being care. Of course, along the way, we also created several publications, and many of our publications are in very high impact factor journals, in Web of Science journals. And a number of our publications, interestingly, have been cited internationally. And these are the publications which have been cited internationally by the Australian Law Reform Commission for Elder Abuse Inquiry, for example, for the US CDC, from Canada, and in the UK, in Australia, and in the UK. So we also developed 3 teaching manuals, one clinical pathway, a reporting form for suspected or confirmed elder abuse neglect cases. And these are the manuals and the clinical pathways is the forms that we developed. And we wrote several books on protecting the elderly against abuse and neglect. And I was involved in writing many of these books. We even had a chapter in an APRU book. APRU stands for the Asia Pacific Rim Universities. It was a book on global health leadership. And we had a chapter just on addressing elder abuse and neglect in the graying Malaysian population, which is our peace initiative. So, did we achieve our objectives? Well, practically yes. We examined the magnitude, the risk factors and consequences of abuse and neglect among community dwellers and institutionalized older people. We managed to investigate the role of caregivers trained in preventing elder abuse and neglect. We managed to provide education and training to healthcare providers, doctors and nurses. And not only that, we provided education and training to caregivers, who were the formal and informal caregivers who provided care for the elderly. And we understood the gaps and refined the law to address the gaps through a comprehensive approach. A few important points, of course, in trying to do this, to achieve our objectives, we found a few things. One, we have to map our stakeholders early, who they are. And we have to get local scientific evidence, not just quoting somebody from evidence from another country. And we had to get buy-in very, very early on from the grassroots as well as the highest levels. And it helped that if you show up in lots of places where media, social media, and listen, you understand and find out what the problems or issues from the ground are. So after all that, then the so what question came. We know that actions have consequences. Community engagement, advocacy, and awareness led to a very important realization at the end of a project, was that Malaysia needed legislation for the elderly. And I'm happy to tell you for the last 1 year or so, our team has been entrusted by the Ministry of Women and Family Development with a very important task, which is to formulate an Act of Parliament for the elderly. The original timeline is about 15 months. We've somewhat exceeded that. We have because of COVID, and the process is a bit slow. We are almost there and having this Act of Parliament. And in trying to formulate this Act of Parliament, we had to engage again the very community that we were trying to protect. So I'm very happy to tell you they are almost at the end of this consultancy to create an act of parliament resulting from things that we found through our community engagement on the elderly. Thank you very much.
Professor Awang, thank you very much for your presentation, and really congratulations on the work that you and your team have done over the last, well, about decade or so. Permit me to ask you this question, Prof. Awang. In tropical countries, there could sometimes be a disconnect between the academics and the practitioners, but you seem to have bridged that gap. So what do you think is the ideal, say, role for academics and universities in tropical countries as we try to achieve real world outcomes? Over to you, Prof. Awang.
Yeah, one of the things that we found made for success in our endeavor to understand and reach out and really make an impact in the community was that many of the state directors and the state health officials were our graduates. So because we kept in touch with our own graduates through our Facebook, through our alumni engagement, we were able to convince them that we were trying to do things which went beyond academia. And so I think that has made a lot of difference in trying to translate what would have been merely academic outputs to real outcomes in the community. Hence, when the Ministry of Women and Family Development asked us whether we would like to do this consultancy job of creating a piece of legislation for the elderly, we said yes, because it came from the work that we did over the last 10 years or so. And we think that we've got to finish this job because it's not just about getting things from the community, but about giving back to the community things which will make an impact to the country. So I'm very happy, and Prof. Noran, which is leading the team, has been one of my mentees, I think, for many years now. She was my supervisee from the masters, and of course now she's a professor in her own right. I'm very happy to see that happen. Thank you, Dr. Ko.
Terima kasih, Prof. Awang. Ladies and gentlemen, what a rich set of comments from firstly Dr. Singer, and then over to Anne, and then to Prof. Vivian, and then to Prof. Aminata, and now Prof. Awang. We're at the end of the say presentations from the panelists, but allow me to have a very short summary, and then we'll have an open Q&A session where I'll be very pleased to read some of the questions that have been proposed by our attendees. And if at some point you would like to ask the question directly and you'd like to verbalize your question, please raise your hand, and if possible, I will call on you, but we'll have a slight priority for the questions that were typed out in the first instance. So as a brief summary, ladies and gentlemen, Dr. Singer mentioned about the importance of primary healthcare and proposed 3 specific solutions for how we can achieve vaccine equity, and took us through the burden of disease in tropical countries, noting that there has been a lot of progress that has been made, but it's plateaued over the last few years, and COVID may even worsen the plateau, and we need to take some firmer actions in order to return to the progress that we made previously. Professor Vivian Lin spoke about the non-medical, or social determinants of health, focusing on various things like employment or housing standards or the burden of care, indicating that there is a need for us to have, say, even political solutions to increasing health, especially the equity of health in tropical countries. Professor Aminata spoke a lot about the importance of education, giving its benefits in Senegal and also conceptually speaking, and noting for us that Senegal spends a large percentage of the government budget on education, indicating the importance of it to health and also to broader socioeconomic outcomes. And finally, Professor Awang gave us 2 excellent case studies about how academics can actually bridge the gap between theory to implementation and achieve real-world outcomes. Ladies and gentlemen, that's a brief summary of where we've gone in the last about an hour and 20 minutes. It's my privilege to ask the first question, if I may. This question is open to all of the 5 panelists, and if you would like, please feel free to switch on your videos right now so the participants will be able to see you. It's an open question to anyone and not addressed to any particular person. In the last 1 year of fighting COVID, because COVID is certainly the disease that we're all concerned about right now, in the last 1 year of fighting COVID around the world, what is one best practice or lesson or success story that you can share from a tropical country that you think that other countries around the world will benefit from? So the floor is open to any of the panelists. What's one best practice or lesson or success story from a tropical country that you can share for the rest of the world? Over to any one of the panelists.
Yeah, can I?
Of course, Professor Aminata.
Okay, I just want to share Senegal experience. I think that early detection on infect people to isolate and treat them effectively is a very good practice. And the fight against COVID has been made a national priority. A wide variety of departments were mobilized while developing outpatient care. That is care outside hospital, so that people do not all rush to the one location and contaminate one other. I think in addition, respiratory specialists, including those working in the private system, were deployed to take care of diagnosed patients. A peripheral health facility, health outposts, clinics, and centers were also mobilized, and communities, scientists, and the media were closely involved. Concerning communities, we work with the nurses in charge of health outposts and communities health officers called Bajanugor, neighborhood good mothers in Wolof, who were employed to relay all announcements and information concerning virus prevention and care. And scientists help public health decision makes understand the virus and conduct operational research on preventative measure and treatment. So I think what was very important is the engagement, the involvement of all the actors and all the community. Thank you.
Thank you, Professor Aminata. It looks like Anne might want to say something.
Oh, I certainly could. My comment is not really about health innovation specifically. It's more about in that social determinants of health space, if you like. But I recently learned that Bangladesh, during the very beginnings of the pandemic, so we're talking about March in 2020, actually reconfigured two of its state television stations that are normally used to, display parliament sittings and the like, to provide lessons to children at home during the pandemic, with the acknowledgement there's very little online learning that can happen in Bangladesh because internet access is far lower than you might actually consider. So there was television stations teaching students. For those students that didn't have a television, which was actually about 44% of students, they set up radio stations that taught those same lessons. So what that has provided is kind of this continuity of education that may even go beyond the pandemic. It'll go beyond kids going back to school, because it is actually reaching out of school children that were not in school in the first place. So that to me will have far-reaching positive public health impacts going forward.
Thank you, Anne. That's a great example from Bangladesh. Over to Professor Vivian.
I think the thing when we look at the pandemic response from a year ago, we've sometimes veered towards talking about the Asian exceptionalism. And I think what we see across Mekong countries, Singapore, so many countries in this part of the world is actually acting quickly. That's the single most important thing. Now, if you act quickly and don't do the right things, of course, that's not good enough. So I think what we see in this acting quickly is recognizing that the science is evolving and tracking that science, and then having this combination of both the traditional public health measures with the community outreach. So getting people understanding involved in some countries, remembering the history of SARS. Actually in the Pacific, they had to actually just get the community to really understand that, like for instance, in Samoa, they lost a third of their population back in the 1918 swine flu epidemic. So there's lots of ways of engaging the community and ensuring that they are part of the government acting quickly.
Thank you, Prof. Vivian. Dr. Singer, and then Professor Awang, sorry.
No, Professor Awang, please go ahead. I'll go after you.
Yeah, okay, sure. If you're looking for a high-tech approach, then I'm not sure you call Taiwan a tropical country or subtropical country. Certainly not tropical in the sense that it's like Malaysia, but certainly it's a very high-tech approach. That's lots of digital epidemiology and so on. But if you're looking for a traditional public health approach, low tech, I think Vietnam would stand out as a very good example. In more tropical, Singapore is a very good example, where I think primarily that early they listen to the science, then they look at the evidence and they follow the evidence. I think when you do that, I think you'll probably do well. And I think that's probably true for just about every country which is doing this. So the countries which have done well are the ones which have acted early, like Professor Vivian has pointed out. Yes, and they followed the evidence, I think, and listen to the evidence and not send mixed messages. And you get these mixed messages. I think people get confused, and then there's a trust deficit which builds up, which is going to be a problem later on when you introduce vaccines and so on. I think we are finding that out now too. Yeah. Mr. Peter Singer, maybe. Yeah.
Thank you. Yeah. No, I just wanted to agree with what actually all the other panelists have said, and maybe synthesize it in this message. Leadership is the ultimate vaccine to COVID and to the conjoint challenges we face in climate, in economic inequality, and in racism. What I think all those examples had in common was leadership. And we don't think about that a lot, but in fact, there's a 50-fold difference in cumulative mortality. If you just look, for example, at the data, at our world in data, 50-fold difference in cumulative mortality from COVID, even across G20 countries. It's even bigger if you look across all countries. And so something has to explain that. And we know it's not the capacity alone. It's a more dynamic process that includes a number of things like decision-making and engagement of communities, like Professor you were talking about, and a broader look at multi-sectoral, like Professor Amanita was saying. But I think what it boils down to is a little bit of luck and some leadership. Leadership is the ultimate vaccine.
Thank you, Dr. Singer, and thank you for all the panelists as well. I thought the first round of questions was a great opportunity to listen to everyone, but allow me, if I may, to maybe make the panel a lot more looser. This means that in the next few questions, anyone can feel free to jump in at any time, so we'll have a bit of a conversation going. But allow me maybe to ask Dr. Singer to pick up on some things that she said about leadership. There's a question addressed to you, and it would be great to hear your thoughts before we then open it up to anyone in the panel who might want to share anything, and we can make it a little bit more relaxed and casual. Dr. Singer, the question is from Professor Chan, who is an anesthesiologist in Malaysia. What is the World Health Organization's stance on asking the various pharma companies to give up their patents so that we can have domestic manufacturing, as you have mentioned, or even regional manufacturing like Siam Biosciences is doing in Thailand, potentially for Southeast Asia? Dr. Singer, over to you.
Yeah, I'll answer that question very specifically. Let me say overall, the way I think about this is the following. Give a country a vaccine and they vaccinate for a day. Teach a country to manufacture vaccines and the citizens will be vaccinated for a lifetime. It's a takeoff on the fish saying. And I think that's very relevant to the question that Professor Chan asked. So very specifically, Dr. Tedros outlined a four-part approach to this domestic production issue, the fourth part of which has to do with intellectual property. Firstly, there's partnerships on fill and finish. That's the very last stage of the vaccine production chain. And it's a good way to get things moving quickly. Secondly, he emphasized, and the World Health Organization is actively pursuing all these paths. Secondly is the issue of bilateral technology transfer. And there's good examples of that, you know, Oxford AstraZeneca, and I'll use the example of SK, because those are your initials as well, I think, in Korea. But that's an example of bilateral technology transfer. Thirdly is the multilateral technology transfer, or globally coordinated. And this is going to become extremely important. You know, the best historical example was between 2006 and 2016, the knowledge translation that occurred related to influenza vaccine production, I think is a very important precedent, and kind of watch this space for more on that multilateral. And then finally, to come to Professor Chan's question on intellectual property, which I do think needs to be looked at in the context of technology transfer, know-how, and frankly, innovation. To come to his question, WHO has supported the proposal of India and South Africa to the World Trade Organization in terms of temporary suspension of intellectual property rights in the midst of the COVID-19 emergency. So I think WHO is working on a wide range of approaches related to technology transfer, know-how, intellectual property, all of which come very closely together, including some questions about finance and science capacity that are also in the chat that we'll come to, no doubt. Working on all those approaches at the same time on domestic manufacturing, the third D, to complement the other two Ds, dollars and doses, because there is an immediate challenge, of course, to get vaccine doses to people and to be able to pay for that. Thank you.
Does any one of the panelists maybe have anything to add on to the topic of what WHO can do, say more? And I'm struck by something that Prof. Awang has mentioned just now, the distinction between dissemination and engagement. So this is, I think, a great opportunity to speak with Dr. Singer and share some of your thoughts. Prof. Awang, maybe.
Sure. Yeah. You know, one of the things about this pandemic has shown us how trust deficit can lead to lots of problems later on. So the messaging right from the very beginning has to be very clear, and you can't send mixed messages and expect people to accept that your messaging is correct, because I think mixed messages confuse people, and I think speaking from the Malaysian point of view, my own experience is that I think we have not made use of behavioral scientists and communication specialists enough in this particular pandemic. It's not that we don't have the science. We do have the science and we do have the knowledge, which is building up day by day. But we don't understand why people respond in the way that they respond. And I think we need to get past that. You know, you can buy 500% of the number of doses that you require, for example, but if you can't get people to accept that they need to be vaccinated, for example, it's not going to work, and those doses are going to go to waste. I think we are already seeing that happen in some countries. We're seeing the level of trust in the kinds of vaccines. Of course, the publicity which surrounds every conceived, preconceived or misconception about side effects and so on being blown up proportion, making things just very difficult for countries to roll out their vaccination drive effectively. So I think we need to get that sorted out correctly. I can't think of something which has probably not been done as well as they should as communication and behavioral science. I'm sorry to say this pandemic has shown up that we are just not communicating this properly, I think, and we're not engaging people. We're not listening to them. It's a very much a one-way kind of thing. And the project which I've shown you has shown us that community engagement is a two-way process. So we may listen to people, we trust people that they will make this decision because we think they are reasonable enough. I always believe that, and I'm always an optimist. I believe that if you trust people to do the right thing and you explain to them in a non-condescending manner, that they will listen to you. And you have to show that you are basing it on the science and not on whatever theory you have behind it. Yeah.
Thanks, Prof. Wang, for taking us to I guess the vaccination program that's usually done at the country level. It would be great to explore that a little bit more, but allow me to return a little bit to the question of global equity of vaccines to centralize the discussion there. And I'm sure we'll have some time to go into the country level in a few minutes. Professor Vivian, if I can ask you, do you think what Dr. Peter Singer has mentioned earlier is adequate? I think the World Health Organization is really on the right track, but I guess the political elements or geopolitical elements will have to come in play as well. So I'll be curious to ask your thoughts about whether or not more can be done by, say, superpowers like the US or China in order to ensure more global vaccine equity, or there could be a third set of actors that you might propose. Over to you, Prof. Vivian.
Look, I think one of the really interesting things about this pandemic is that the countries which are the big donors to the WHO were also the first in the vaccine nationalism race. It's really quite ironic. And in many ways, I suppose it speaks to all foreign affairs essentially being domestic policy, or whatever you do in that global space, you're actually also speaking to your domestic audience. And as we see domestic politics becoming polarized in many countries, reinforced by the social media bubbles that people live in, we see these narratives that are very, very difficult to overcome. So I think when we see problems of, the trust deficit, it's not just about the COVID vaccine or which of the COVID vaccines. It's this much, much larger problem that we're facing. So, we have to kind of think about how to work at multiple levels, almost simultaneously, right? Because we've got to actually really address the vaccine hesitancy. And to do that is fundamentally a local issue, not just even national. And it takes many different kinds of social institutions, but that can also be global networks across these different kinds of communities. So the solidarity is not just about national, it's not just about, more money for COVAX, even though that's important, but it's about this broader mobilization that actually needs to happen. And if I were to, I would not want to be putting my eggs in the superpowers basket, because superpowers have superpower agendas.
Thank you, Prof. Vivian. To just synthesize both the answers, which I thought were very holistic, is to say that we probably need a suite of solutions, all options on the table all at the same time, because we need multiple people to be fulfilling their roles so that we can achieve vaccine equity. Thank you. If I may go to one of the questions that have been asked as well, and this one's addressed actually specifically to Dr. Singer, but I think it'd be great to hear what other people think as well. What is the role of the World Health Organization in creating or developing health infrastructure in low-income countries? And it would be great to hear the thoughts of Anne and Professor Aminata, following Dr. Singer's initial thoughts about the role of WHO in health infrastructure development in low-income countries. Over to you, Dr. Singer.
Sure. Well, depends what the questioner means by infrastructure, right? But I think that's why primary healthcare is so important in the recovery, and a big focus on equity. Primary healthcare is some of those upstream levers. It's about finance. It's about health workers, many of whom are women. It's about the physical infrastructure. It's about the drugs and the vaccines. So in a sense, primary healthcare is a good entry point into that question. The only other point I want to make, though, is that primary healthcare does embrace the type of community approaches that Prof. Awang was talking about, the social determinants that Dr. Vivian was talking about. It's very important to realize that, there's a long history of primary healthcare. People often think about it in terms of essential services, but it's actually the glue that pulls together the SDG-based, shall we say, triple billion targets that all governments of the world endorsed in WHO's strategic plan, which have to do with 1 billion more people with universal health coverage, 1 billion people better protected from health emergencies because of the importance of essential public health functions as well, and 1 billion people living healthier lives and healthier populations, which has to do with the community engagement and empowerment. It has to do with the social determinants that Dr. Vivian talked about. So I think the question on infrastructure really goes to the recovery. It goes to the importance of equity in the recovery. It goes to the importance of a holistic approach on primary healthcare in the recovery. And it does also go to the question of finance, which I won't get into in detail now. But with tens of trillions of dollars of deficit spending, there's obviously going to be pressure on government budgets going forward, which means that political leaders will need to really have learned this lesson about the importance of health, the centrality of health, financing health, the importance of preparedness, not repeating the cycle of panic and neglect. And there are other approaches to innovative finance and social finance that we can further explore. But if there's one lesson here, it's that governments are central and government spending is central in the response to the pandemic. And so the World Health Organization, which was the question, is involved in all that. And to the points made earlier, it is the organization for 194 countries in the world. And that's a very, very important point about governance, which is really one of its key assets. It's the only place in the world where 194 health ministers can come together, work through their issues, find common cause, and move forward together to make the world safer and make people healthier. Thank you.
Thank you, Dr. Singer. I'm struck by this question because as we consider how to build a fairer and healthier tropics, we have to talk about infrastructure. Some of that is physical, some of that is very intangible. So Anne and then Professor Aminata, if we can hear your thoughts, please, about what sort of infrastructure do you think might be necessary for the tropical countries to build back fairer and healthier? What sort of infrastructure is needed and how might we get there? Anne, over to you.
Well, what I might start by saying is actually we don't want to, I guess, underestimate the infrastructure that already exists. I think we talked about the vulnerability of tropical countries, their burdens of diseases, but all of those factors actually make them incredibly resilient to something like a global pandemic. And we've actually seen that play out in a number of tropical countries because of the experience in Southeast Asia with SARS and swine flu. There was a lot of preparedness in the system already. And in Africa, for example, the Ebola epidemics actually had, I guess, health systems in place with very little resources, but able to, I guess, punch way above their weight. And that's why I think we've actually seen a kind of disproportionate impact in developed countries by COVID-19, is because many of the developing countries in the tropics have been bearing this health burden for a long time and thus have a degree of preparedness that we need to appreciate. Obviously, in terms of going forward, and building back better, there is probably no need to reinvent the wheel when it comes to public health, community health. I think, Peter, you talked about the primary health kind of part of what WHO delivers, and that falls down into those, the regional clinics that deliver antiretrovirals for HIV. Well, they can certainly deliver COVID vaccinations as well. Those community health workers in Bangladesh, in Ethiopia, in South Africa that are really good at delivering that last mile healthcare. They're going to be vital in I think what you said, Awang, about the communication and the information that's going to be required to roll out the solution. So I guess I'm going to be optimistic here and say that there are incredible there's incredible structures already in place that can be utilised and built upon to come out of this pandemic as quickly and as safely as possible.
Thank you. And Professor Aminata, what are your thoughts about, say, the infrastructure that either is present or might be needed? Professor Aminata? Well,
excuse me, I was muted. I just want to say that in tropical countries, I think we have a deficit. We have fewer resources in health system in terms of infrastructure capacity, but also human capacity to address the burden of disease in tropical areas. I think what we need is certainly to have better infrastructure in tropical countries, but we need also to put a lot of effort on human capital. Infrastructure is important, but I think it's not sufficient. And what can WHO do? And I think in my country, WHO don't put health infrastructure. They are just advisor of government, and they do some effort to collect data from healthcare and so on, but they don't invest in infrastructure. All infrastructure we have in Senegal come from domestic resources. And I think we are far away from our needs. We really need to put more investment in infrastructure, and WHO can help because they can raise awareness of the government to health importance, and I think they can play a role to help building more infrastructure for our countries.
Merci beaucoup, Professor Aminata. That's a great set of comments about health infrastructure that is, say, non-physical in terms of human capital and also the role of international agencies. Ladies and gentlemen, at this point, we're about 12 minutes left into our fascinating webinar. There are a couple of hands up. Allow me to call on one of them, and that's Professor K.S. Jomo, who is an economist and worked in a senior leadership position in the United Nations previously. Over to you, Professor Jomo, for us to hear your thoughts or your question.
Thank you. Thank you very much, Dr. Kaur, and thank you to the panel for a very interesting set of interventions. I would like to address a point made by Professor Lin and Dr. Singer, and that is how we transform the situation which we have in the world today of access to vaccines into hopefully a better one. Professor Lin is absolutely correct that we have the superpower rivalry, which is a problem. But as Dr. Singer and others know, we have had a situation in the past where superpower rivalry between the Soviet Union and the USA resulted in the eradication of smallpox within a decade. And that was largely done by the superpower rivalry in the context of the World Health Assembly. Now, we have a situation now where where under US law, it is possible because Operation Warp Speed funded the development of the Moderna vaccine for the government of the United States to actually deploy. And furthermore, we also find that the principal directors of Moderna, who include many people who used to be at University of Pennsylvania and MIT, have been very open and even made pronouncements to the effect that they do not want to profit from the pandemic, at least during the duration of the pandemic. So with that situation, is it possible for the WHO to prevail upon the US government to make information available? Because as the WHO's initiative on knowledge sharing has not worked as far as voluntary participation by the vaccine developers is concerned. So this is one way we could appeal, because you have a situation where the United States is obviously very keen to try to enhance its so-called soft power, and this is one way to do so. So because I think unfortunately, even if the South African Indian initiative succeeds at the WTO, it would not mean anything, because the knowledge itself is not patented. It's not available through the normal processes of access to patented information. So it becomes very crucial to break the logjam and because as the WHO has pointed out, 2.5 million people will die unnecessarily due to the delays in vaccination. So I think we have an opportunity here where we can turn a huge problem, as Professor Lin has emphasized, into something which might be advantageous. And I finally would just like to conclude by urging that we don't think about building back better, but let's build forward better. Because I think going back to the status quo ante is not something which is especially desirable for a whole host of reasons all panelists have talked about. Thank you very much.
Thank you, Prof. Jomo. Dr. Singer, Professor Lin?
Maybe Professor Lin would want to go first. Then I'll happily come.
Firstly, I like that build forward better. Thank you, Jomo. Look, I think that superpower rivalry, you don't want to get caught up in it, but it's not necessarily a bad thing, just as competition is not a bad thing. So, I mean, the other example I would say is the US went at it with PEPFAR on its own and delivered great benefits. So if superpowers can actually, for whatever their agendas, deliver good benefits to parts of the world, let them do so. It's much better than them spending money on weapons and military hardware. And so it should be encouraged in that sense. You know, I think there's probably a lot more that could be thought about in terms of the global economy beyond the political, you know, superpower bit. I was very interested. What was the latest US proposition about taxing, having a minimum level of corporate tax across the world? I think there's a lot more that could be thought about from those kinds of strategies as well. So I would, you know, encourage a strong dialogue, not just through formal multilateral organizations, but also through various global networks, because at the end of the day, pressure from civil society is really important at various forms. So I would really encourage that, and I leave Peter to think about the intellectual property issue.
Thanks. I mean, I just build upon, you know, Professor Jomo asked a very thoughtful question, and a lot of the answer was contained in the question in a very thoughtful way. Let me just amplify two things that he mentioned and build upon them, and also that what Dr. Lin was saying, which I fully agree with. Number one, Professor Jomo did point out that some of these vaccines, including some of the newer platforms, remember there was no licensed mRNA vaccine platform prior to the COVID ones. He pointed out that some of these platforms and some specific examples, he used one specific example, the Moderna, largely were paid for in terms of their development by public funds, by government funds. And so the question is, how can we actually turn this concept that vaccines are public goods into reality based on the fact that they were largely paid for by public funds? And that's a very, very good question. And all I will say is that WHO has launched an economic council chaired by Professor Mariana Mazzucato, and her work is exactly about that. It's about thinking about innovation in the context of governments, the social life, et cetera. So just to say, he really landed on a good point there. I'm just agreeing with him. Secondly, on the multilateral diplomacy, maybe all I'll point out is introduce the idea, it hasn't come up yet in the panel, that Dr. Tedros supported actually an initiative of President Michel of the European Union to introduce a pandemic treaty. And there was an op-ed piece with about 25 heads of state and Dr. Tedros last week supporting the notion of a pandemic treaty, which really would have four elements at a type of granular level. Firstly, issues in preparedness, so information flow, early warning, et cetera. Secondly, issues in countermeasures, which is where the vaccine sharing, domestic production, but also diagnostics and drugs and oxygen and everything else would fit in. Thirdly, issues in finance. And fourthly, issues in mutual accountability. And Dr. Tedros has also launched something called the Universal Health and Preparedness Review, where countries actually would review each other. And that would be a very interesting model of mutual accountability. So this international diplomacy, I think, has a vehicle for forward motion. And of course, Dr. Tedros expressed this is an opt-in model. And the hope would be that all countries in the world, including for the countries that were mentioned earlier, would support this. And it does provide a way for the multilateral system to go forward. Because remember, we knew that a pandemic was coming. We didn't quite know how bad it was. We were caught in a cycle of panic and neglect. You know, there was Ebola, there was MERS, there was the early SARS 2003. It's not a surprise. Shouldn't have been a surprise to anybody. The question was, did we act? The answer was no, we didn't act. We weren't prepared. So now the question is, can the countries of the world work together actually to make sure we're prepared for the next one? And that's where the multilateral diplomacy comes in. So I just wanted to thank Professor Jomo, and I amplified his 2 points there on public finance of some of these new technologies and the implications of that are being tracked through, including with regard to the specific example he gave of Moderna and US government funding. And then secondly, I wanted to just mention this pandemic treaty because it does provide a vehicle for the type of diplomacy that many of the wonderful panelists have been talking about and that we all yearn for. Our heads of state working together to protect the world against future threats and to recover from this one.
Thank you, Dr. Singer, Professor Lin, and Prof. Jomo. We're at time, unfortunately. What a fascinating conversation that we spent the afternoon or the morning on. Allow me to have a very brief summary before turning over to Sufyan, just to end the conversation. Maybe at the local level and also at the global level. At the local level, tropical health requires tropical solutions. I really like what Anne has said, and a lot of it will depend on the tropical countries just sort of leading their own change and having their own solutions. But at the global level, we also need reforms to global health governance, the political economy of global health, the intellectual property regimes, and so on. And all that requires two things. Firstly, that we understand that health remains a political choice, and equity is a political choice as much as it is a scientific and ethical one. And secondly, to be able to achieve this political choice, we will need a coalition of the willing, the able, the relevant, as many stakeholders as possible so that we cover all the bases. Ladies and gentlemen, thank you very much again for joining us today. We're very happy to have you. Sufyan, over to you to close us out.
Thank you very much, Dr. Swee Keng. And on behalf of the Mahathir Science Award Foundation, the International Science Council Regional Office for Asia and the Pacific, and the Academy of Sciences Malaysia, again, we are extremely grateful for the contributions of everyone here today. On behalf of myself and certainly all the attendees as well, I learned a lot from this discussion today, and unfortunately it has to come to an end because I think if there were no time constraints, it could probably go on for another half an hour, 1 hour. No, thank you very much to everyone contributing to this webinar, and to all the attendees as well who have spent their evenings, mornings with us as well. Just to like to say that this webinar is also recorded and will be shared through the YouTube page of the Academy of Sciences Malaysia. So if you would like to share this video with your networks and colleagues, that would be good, because like was discussed in the webinar, is that information is vital and information can be good to be shared. And so sharing this video would allow more people to listen into the conversation. So again, thank you very much to everyone, and we hope to see you in the next webinar that we have. Do follow our social media to keep updated with any upcoming webinars. Again, thank you very much and have a good day to everyone.
Thank you very much. Bye-bye.
Bye.